everyone. My name is Hope Frost, and I'm pleased to welcome you to the recording of this webinar, which focuses on obesity management training, your guide to NHS approved weight loss drugs. I hope that you find it useful. Your speaker today is Professor Rob Andrews. He's the Associate Professor of Diabetes and Endocrinology at the University of Exeter Medical School. For further training and events, please do visit our website at www.diabetes-nnf.co.uk. Thank you very much for watching, and I hope that you find it useful.
Thanks very much, Hope, for introducing me. Hopefully everybody can see me and hear me. So my plans are over the next 40 minutes to go over what options you have available to help patients with losing weight or helping with their complications of weight. Just to show this is my conflict of interest, so please note that I do a lot of studies. So I am involved in lifestyle studies and also have been involved with commercial studies looking at all of these drugs that I will talk about today. I have previously been paid to do education talks by the companies that make the drugs that we're going to talk about today, but I'm not being paid to do this talk. And it's worth also mentioning that these are my opinions that I'm expressing, not my university's or my hospital's opinions. So what I plan today to do is go over just a couple of facts to consider before we wade into the drugs. And I am going to talk about all of the drugs that you have in your arsenal to help with weight loss, just because some very interesting things come up about what protective effects some of these drugs have for people who are overweight. And then finish up by just talking about perhaps stratifying the use of the most recent ones, because we're having difficulties getting hold of them. So the first thing to think about is obviously the cause and consequence of obesity. So there are lots of causes of obesity. It's also worth bearing in mind that when we talk about these drugs, that they shouldn't be given in isolation. So this is a lovely study that has shown the benefits of lifestyle when given with alone or with drugs. So you can see that with drugs for weight loss alone, that actually weight loss is not very large. If you give drugs plus brief therapy, it gets a bit larger. And if you give combined therapy with lifestyle, then that's the effects where you see the big weight loss. And it's worth bearing in mind that in all of the trials that I'm going to show data from, in the arm that they got the drugs, they did get a combined therapy of lifestyle advice plus the drug. So ideally, if we want to get those results, we've got to try and replicate that within the NHS. The other thing that's worth bearing in mind, particularly when you're talking to patients, is working out what it is that they want from their weight loss, and also considering what you're trying to do. And you can see from this diagram here that actually the percentage of weight loss that you get will determine what effect you can have on some outcomes. You can see that with a very small percent of weight loss, you can prevent type 2 diabetes, and you can improve ovulatory cycles to help people become fertile. At a 5% weight loss, then you can see that there are improvements in quality of life and knee pain and fatty changes in the liver. And then when you get to 10%, you can see greater changes such as reversing sleep apnea. So we're going to go on to the first drug, which I'm going to talk about, is Metformin. This is a really old drug that's been around since 1954, which is when it's first licensed in the UK. What do we know about how Metformin acts? Well, what we do know, we're still not entirely clear as to actually how Metformin acts, but we do know that it definitely reduces production of glucose from the liver. And we also know that by acting through mitochondrial, that it improves insulin sensitivity. We know that it decreases inflammation, and there is some enhanced release of GDF15, which is how we think it affects weight. In meta-analysis of studies, and these are individuals with and without diabetes, there is a rough weight loss of around 1.5 kilograms, with this being a definite effect, so not crossing the line of no difference. So there is some effect from weight loss. The other thing that we know from trials and from looking at long-term data that we can now get hold of both here and in America is that metformin has an effect on all-cause mortality in people with type 2 diabetes. And shown here is the effect on overall survival in individuals who are taking metformin compared to individuals taking SGLT2 inhibitors, which has been the real new kid on the block for preventing heart disease and heart failure and protecting kidneys. And as you can see, actually, in people with type 2 diabetes, the best drug for preventing deaths is actually metformin. And that really is why the guidelines as to having metformin as the first choice, still, although they've been challenged, should stay, and that we should be starting individuals with type 2 diabetes on metformin if they can tolerate it. The other benefits from metformin are that in people with pre-diabetes, we know that it halves the risk of getting diabetes. So that's from the diabetes prevention trial, the American Diabetes Prevention Trial. There's also been evidence that individuals who are either starting on antipsychotic medication or are changing over to a different antipsychotic medication is that if you commence them on metformin, you can, on average, reduce their weight gain by 3 to 4 kilograms. So that could prevent them getting diabetes, because as we said, the change in the diabetes prevention trial was about 2.5 kilograms. There is evidence that metformin helps improve menstruation irregularities and helps with fertility. And in people with type 2 diabetes, there is evidence that metformin lowers the risk of cancer, particularly breast, colon cancer, and prostate cancer, and that it lowers the risk for dementia and strokes. There are side effects associated with metformin, and we all know those. So those tend to be stomach cramps, gas and bloating, nausea, and occasionally diarrhea. And there can be B12 deficiency, which has come out latterly. Ways that those can be avoided is to consider extended release metformin, take with food, start with a lower dose and gradually build up. And obviously to avoid the B12 deficiency, take B12 supplementation. So the first summary that I would say on metformin is that it does cause a small weight loss. It's cheap, it's generally well tolerated. It should be given to all people with type 2 diabetes who can tolerate it. And you might consider using this in individuals if you're trying to prevent diabetes, if you're trying to help with PCOS or fertility, and if you're trying to prevent weight gain with antipsychotic medication. The next drug to consider is Orlistat. And again, this drug's been around for a very long time and can now be bought over the counter. This drug acts in the intestinal lumen. So what it does is works by preventing absorption of fat that you consume in your diet. And there's a 25 to 30% less absorption of fat. In trials, again, if you bring all these trials together in a meta-analysis, there is evidence that Orlistat does cause weight loss, and it's getting us a weight loss of somewhere between 2.5 and 3.2 kilograms weight loss that is seen if you bring these trials together. If you look at individuals who get a 5 or a 10% weight loss, then you can see that there are individuals who do get a 5 or 10% weight loss, but is nowhere near as large as the other drugs that we're going to talk about later on in this talk. Other benefits that Orlistat provides is it does improve the waist circumference. There is an effect on diastolic and systolic blood pressure. It also helps reduce total cholesterol, and it can help with reducing the HbA1c by about 0.4, so similar to a DPP-4 inhibitor. In terms of predictors, and this is the first drug that predictors as to who would lose weight and who wouldn't lose weight, is those individuals who lose more than 5% of weight in the first 12 weeks are likely to go on to be responders, and on average respond quite well. So they can see up to a 14 kilogram weight loss at a year and about 11 kilogram weight loss at the second year time point. So if it is worth trying Orlistat, and if individuals do respond with a 5% weight loss in that first 12 weeks, then they are going to respond very well and can get substantive weight loss. There are side effects associated with Orlistat. So there is a reduction in the vitamin A, D, E absorption. And for that reason, if you are going to go on Orlistat, we suggest that people are started on a multivitamin tablet. And there is some interference in absorption of some medication that are highly lipophilic, such as cyclosporin or amiodarone. The other thing that's worth mentioning for both metformin and Orlistat is that it is safe for individuals that are trying for families. So if you become pregnant on this, there is no worries. Real-world data is not quite as good as what you see in that meta-analysis. So at about a year, you do see kind of a kind of 3.5 kilogram weight loss. But when you're getting out to years 2s or 3s, there is a fall off in the amount of weight that is lost. And the other real problem with the drug is adherence. So what we know is that at a year, only about 10% of people are still on the drug. And at 2 years, that can fall to about 2%. There are things that can help with the compliance, obviously making sure you stick to a low-fat diet, and swaps that you can do with your diet that can help with increasing the compliance with Orlistat. And there is lots of good information available on the internet that you can give individuals when they do start on Orlistat to help them with this compliance. So the summary of Orlistat is that it does cause a weight loss, and on average that's a 3 kilogram weight loss. But as we said, in those individuals, if they get a 5% weight loss in that first 3 months, then they can go on to get a good 11 to 14 kilogram weight loss. It can help, it has been shown in trials to help prevent type 2 diabetes. And as I said, it's safe to use if trying to get pregnant. As mentioned, side effects are quite common, with the major side effect obviously being diarrhea, but then the vitamin problems. And that means that adherence to it isn't often as good. The next drugs to think about are the sodium glucose co-transporter 2 inhibitors, so the SGL2 inhibitors. So normally what happens in the kidney is that glucose in the blood is all filtrated in the kidney, and then has to be reabsorbed, and 90% of that reabsorption back into the blood occurs through the SGL2 inhibitor. The SGL2 inhibitors, so here an example, dapagliflozin, acts on the SGL2 receptor, blocking it, and that increases the glucose excretion from the blood. The nice thing about the drug is that it isn't associated with hyperglycemia, because it gets to a plateau effect of how much glucose it will remove. And losing glucose can be associated with some weight loss. Shown here is what is called a network analysis, and what that enables you to do is to compare the effect of the 2 commonest SGL2s that I put here, DAPA and EMPA, to what the weight loss is compared to other drugs. So you can see that compared to placebo, the average kind of weight loss with DAPA is about 1.8. It's higher with EMPA at about 3.6. And then you can compare it to the other agents. So you can compare it and see whether there's a significant effect, because unfortunately there aren't any randomized control trials comparing these 2 things. So this is getting data and doing a mathematical comparison. But what you can really see is that there's not any convincing evidence for DAPA that it's any worse in terms of its weight loss until you start comparing it with high-dose semaglutide or low-dose semaglutide and high-dose semaglutide. And with EMPA, there's no convincing evidence that the weight loss seen with EMPA is any less than any of the drugs other than semaglutide 2.4. So that gives you an idea that in individuals who are being given this drug, it is causing reasonable weight loss, and that weight loss, particularly in people with diabetes, can be similar to some of the GLP-1s that we use. There are lots of benefits now that have been shown for SGLT2 inhibitors. So we know that in people with and people without diabetes who have chronic kidney disease, that being on an SGLT2 inhibitor can prevent progression of the kidney disease. We know in individuals who've had a cardiovascular event, who have diabetes, that going on to an SGLT2 can prevent further cardiovascular events. We know that cardiovascular events in people who've got heart failure and diabetes, if you're given an SGLT2 inhibitor, that can also help. And that is similarly seen in people who've got heart failure who don't have diabetes. And overall, people with who've been hospitalized with heart failure, if they've got diabetes, if they've started on SGLT2 in hospital, then that can prevent further problems with heart failure. So really a very useful protective effect that you're seeing from this drug. There are side effects that are associated with the SGLT2 inhibitors, and the four commonest are shown here. So volume depletion and dehydration, that tends to happen when first starting them. Can get increased candida infections and increased bacterial infections, and that's due to putting the glucose into the urine. There is euglycemic ketoacidosis. Initially, we thought this was happening in both people with type 2 diabetes and people without type 2 diabetes, but the most recent evidence indicates that this is only happening in people with diabetes. And then there is some evidence with canagliflozin that it can slightly increase the risk of bone fractures. So in summary, for the SGLT2 inhibitors, as mentioned, the weight loss count that we can see is somewhere between 1.8 and 4 kilograms. And as mentioned in that network analysis, the weight loss doesn't appear to be inferior to anything other than semaglutide at 1 milligram and 2.4 milligrams. And the people should be consider giving this to are people with type 2 diabetes who have had a cardiovascular event, anybody who's got chronic renal failure, and anybody who's got problems with heart failure. So now we move on to the glucagon-like peptides. And these were a real revelation because they showed that actually you could reactivate the pancreas in individuals who had type 2 diabetes to make more insulin, suggesting that in type 2 diabetes, the pancreas is stunned rather than with time that the cells destroyed. How do GLP-1s work? So GLP-1s are a natural hormone that are released when food is ingested. And what it does is it acts on the beta cells in the pancreas to enhance insulin secretion. So making sure that more insulin is produced in readiness to clear any of the carbohydrates in the meal. It also suppresses the production of glucagon, so lowers the glucagon, and that will reduce the hepatic output of glucose. And that makes perfect sense because you're going to get some glucose entering the blood from the meal. The other thing it does is it slows the rate of gastric emptying, so it helps with the feeling of fullness, and provides feedback to the brain to say that you've eaten and that you feel full, and reduces the appetite. There are lots of GLP-1s out there. So in terms of diabetes, there's extensive ones available. So the original one was the twice daily exenatide, and there's once daily liraglutide, lixisenatide, then oral semaglutide, and then these weekly agents, so exenatide, dulaglutide, semaglutide. And now there are two agents available for weight loss, and that's liraglutide at a higher dose, up to 3 milligrams, which is called Saxenda, and semaglutide up to a high dose of 2.4 milligrams, which is called Wegovy. If you look at the weight loss across the trials, this is bringing the trials together, and you can see here shown on the side, you can see that the kind of average weight loss until you've kind of get to the semaglutide dosage is roughly what we were seeing for individuals who are on the SGLT2s, so roughly around 4 kilograms or so. But then when semaglutide has come along in terms of the injection, you can see that the greater weight loss is seen in individuals who have diabetes, with roughly around a 7 kilogram weight loss. What about if we look at Saxenda? So that's the high dose liraglutide in individuals who've got type 2 diabetes. So what you can see here is that compared to individuals who had the placebo, is that you're seeing about 6.5% weight loss, with a mean baseline weight of about 100 kilograms in this trial. That's about a 6.5 kilogram weight loss. And interestingly, as shown in the previous slide, this is similar to what you were seeing in trials with 1 milligram of semaglutide. So in people with type 2 diabetes, not seeing a greater effect of Saxenda in individuals with type 2 diabetes. If we go on to look at Wegovy, so that's the higher dose of semaglutide in individuals with type 2 diabetes, you can see here that compared to the 1 milligram, which is shown in blue, that the 2.4 milligram is causing a greater weight loss in these individuals. And is seeing about a 10% weight loss compared to that kind of 6% weight loss that was seen. So semaglutide seems to be having a greater effect in people with type 2 diabetes. If we go to look at these in people without diabetes, so you can see that with both of these, that there is a greater weight loss. So you can see that with liraglutide, that the weight loss seen here was 6.4% in this comparison trial. And you can see that compared to semaglutide, that there was a rate of 15% weight loss. So a really good weight loss with liraglutide and a significant weight loss with the high-dose semaglutide. It's worth bearing in mind, this is the average weight loss, and you can see here the spread of the weight loss that you're getting in these individuals. So some individuals, are losing more than 30% of their weight on either of the agents. So it is, the effect you can see in individuals is individually can be quite different. But obviously we tend to show the average weight losses. Just like the SGLT2, there are really some added benefits from these agents over and above the weight loss. So we know that GLP-1s can help with the cardio-renal systems. So it can prevent overall deaths, cardiovascular deaths. It can also help with protecting against progression of chronic renal failure, and also helps prevent strokes. And interestingly, there is evidence emerging that these agents are probably helpful both in liver disease, so in fatty liver disease, in Parkinson's disease, and in Alzheimer's. For liraglutide, there's evidence in reduction in cardiovascular deaths in people with type 2 diabetes. For semaglutide, there was evidence for reduction in cardiovascular deaths in both type 2 patients and in individuals without type 2 diabetes. And there's in protection of kidney disease in people with and without type 2 diabetes. There are side effects associated with these agents. So the major side effects that can be seen is nausea and loss of appetite. There are problems that people can have with either diarrhea or constipation that they can see. Other things that have been seen, particularly with the higher doses, are reduced bowel motility. So ilices have occurred. And the slowing of the gastric outlet can cause retained gastric contents and aspiration. There is problems with gallbladder disease, and there is a slight worry about acute kidney disease due to dehydration that occurs. Possible AEs that have been worried about are sarcopenia, so loss of muscle mass that happens as the weight drops very drastically, and some worry about whether they increase depression and other problems. And then worries about, as improvement with the HbA1c, whether there's worsening of retinopathy. And then always in that background has been the worry about whether they cause thyroid cancer and pancreatic cancers. And a recent analysis has suggested that there is a very small increase in thyroid cancer, but the benefits gained outweigh that small increase in risk. There are things that can be improved, and if you're looking for a really nice article that goes over things that can be done to improve compliance with GLP-1 inhibitors, this is the article to look at. Here they have looked at ways of helping in terms of when starting on the medication. So the important thing to do is to slow down the escalation if people are still getting symptoms in terms of the dose. And there's no problems with temporary suspending and then restarting. So in the trials, there were a number of people that we would suspend the treatment on those individuals and then re-challenge them later. And on the second challenge, building up slowly, they were able to take the agent. You can also give them anti-sickness medication to get over that first period. And again, that's what was commonly done in the trials. And then obviously if there are certain things that are going on, so persistent nausea and things, then you can think about antiemetics or prokinetics. And if they're having diarrhea, think about probiotics. And obviously they're getting constipation, stool softeners. In terms of particular eating habits that they should be thinking about, the main thing is to eat slowly, only eat if hungry, have smaller portions. It is suggested not to lie down after having a meal up to 3 to 4 hours afterwards, as that will help with the feeling of nausea and chance of vomiting. Try not to drink with a straw because that increases air. Think about low-fat diet, boiling, crinkling clears, avoiding sweetie subjects. And there is some evidence that avoiding broccoli and agents that make amines can also stop the halitosis that sometimes can happen with these agents. And again, what you can do to help with the nausea, think about eating crackers, mints or ginger-baked products 30 minutes afterwards can help, and avoiding strong smells can help. For vomiting, think about smaller amounts at a time and adequate hydration. And then for the diarrhea, think about not too high fiber content foods, avoid sports drinks, and stay to certain products such as chicken broths, rice, and avoiding kind of dairy products. With the constipation, make sure you're getting enough fiber and generous hydration. So in summary, for the GLP-1s, the evidence is from the GLP-1s alone that Wegovy seem to have the greatest weight loss. In people with diabetes, weight loss with semaglutide seems to be similar to that with Saxenda. But Saxenda is a helpful product for individuals who don't have diabetes. And GLP-1 is shown to protect kidneys and against cardiovascular events. And there are ways of helping reduce side effects with these individuals. Now, finally, to think about the new kid on the block, and that's Tirzepatide. So Tirzepatide is a dual blocker, so it has GLP-1 in it, and it has a GIP in it. So as you said, for the GLP-1s, their function is to reduce satiety, so effect on the brain. In the pancreas, they reduce insulin secretion, increase insulin secretion, reduce glucagon secretion. But the GIP will, as well as increasing the insulin secretion, increase glucagon. In the GI tract, GLP-1s do tend to cause nausea. The GIP tends to offset that, so has found to be helpful adding that into with the medication. And there's additional effects on the GIP in that it reduces triglycerides and further increases insulin sensitivity. The weight loss in these agents has been a next step up in terms of weight loss in people without diabetes. So what we're seeing is that if you in individuals that just have the 5 milligram dose, that you're seeing a kind of greater effect than what we were seeing with Saxenda, and a kind of similar effect to the high-dose semaglutide. But if individuals can get up to the 10 and 15 milligram dose, then they're seeing a kind of a 19 to 20% reduction in their weight. So really quite significant. And to kind of give you that kind of ballpark, that's similar to what you would be expecting to be seen with either a gastric balloon or with a gastric sleeve, with only the gastric bypass on average being greater than that at about 27 to 30% weight loss. In terms of weight loss with diabetes, as we've seen with all these agents, there's a reduction in the weight loss, but still quite significant. So at that 10 to 50 milligram dose, you're seeing a 12 to 14% reduction in the weight. The side effects that we see are similar to what was seen with oraglutide and semaglutide, although together it was hoped that the nausea would be less. In the trials, I'm not sure that hand on heart I could say that we saw that. But again, we were able to help people through that by thinking about the steps which I've mentioned with the GLP-1. There are no big CVD or renal studies that have shown that this agent protects against those, or heart failure trials, but they are underway. Analysis of the trials seem to indicate that there is a signal that they will be doing the same thing as the GLP-1s alone. So in summary, they cause the greatest weight loss in people without type 2 diabetes, have similar weight loss to people with semaglutide, but there isn't any head-to-head trials comparing that. There is a head-to-head comparing Tirzepatide to 1 milligram semaglutide, and of course Tirzepatide wins that. As I said, similar effects similar to GLP-1, but we don't have any CVD, renal, or heart failure outcomes studies. So just think about who to target, and it's worth kind of bearing in mind is that not all people who've gained weight have the same cardiovascular or comorbidity profile. So you can see that Asterix, compared to the Chief, are two different people, and that's really important. And we're beginning to learn that. So this is a lovely study. It's worth reading if you're kind of interested in understanding about the genes. So this is comparing favorable genes and unfavorable genes, both of which cause weight gain. And what's shown here is in the clear square is the effect of BMI on the risk, the effect of body fat percentages in the darker filled in square, and then unfavorable being the triangle shaded, and favorable being the triangle not shaded. And what you can see is that if you get the favorable adiposity genes, that actually your risk of getting type 2 diabetes, even though you're overweight, is vastly reduced. And you see the same thing with hypertension, with polycystic ovary disease and coronary artery disease. Similarly, if you look at strokes, peripheral artery disease, you can see an effect, but not as much effect as seen for heart failure, atrial fibrillation, but it is seen for chronic renal failure. And what that's telling us is that individuals who have particular genes are going to have less risk of gaining weight. And we need to start thinking about that as we go forward as to what treatments we're offering those individuals in terms of trying to prevent events. Another way of looking at that is to look at how many actual end stage or comorbidities individuals have. And one way of doing that is this Edmonton Obesity Score that stages people dependent on whether they have metabolic, mechanical, mental, or other problems related to their obesity, and stages those individuals from stage 0 to stage 3. The advantage to the staging over just purely looking at BMI is that it can give an idea as to what will happen to those individuals over time. And shown here is these individuals staged as to what happens over the next 200 months in terms of survival. And you can see that if you're at Edmonton Obesity Stage 0, even though you've got a BMI over 35, that there is no increased death rate over those 200 months for those individuals. If you have 1, then there's a small loss of life. But if you have an emphasis stage 3, then your chances of being alive at 200 months is about 50%, which is similar to having stomach cancer. So there's a difference in the risk to individuals who are overweight, depending on how many comorbidities they have. So finally, finishing up what we do in these individuals when we have we're not able to prescribe because there is problems with getting SGLT2 inhibitors. So it's with getting the GLP-1s. And the high-dose semaglutide is only available from secondary care, and many secondary care clinics haven't had permission to prescribe this. So currently at the last call, I think only seven secondary care clinics were prescribing the high-dose semaglutide. This is the way that I kind of think about it, and this is purely kind of our thoughts about how we kind of think about it. So in people with type 1 diabetes, as you said, the first step should be metformin. If they're within 10 years, we should be considering offering them the remission diet, as that has been shown to work very well. And then we can divide people into whether they're trying for a family, whether they've got chronic renal failure or past cardiovascular events. If they have that, then the kind of steps I would kind of be considering would SGLT2, and then at semaglutide, if you're able to get hold of that 1 milligram. And if they don't get the 10% weight loss, then those individuals could be looked to the local centres for going for the 2.4 milligram dosages. If they're trying for family, then you're thinking about Orlistat as the next step. If that still doesn't cause enough weight loss for ovulation, then you can think about a GLP-1, but they need to go onto the pill and then get their weight loss and then come off the agent for 2 months before starting to try for a family. If they've fulfilled none of these kind of criteria, then Tirzepatide is available. So that would be the step to go, is down that line. And certainly 2.5 and 5 are available, and the other doses are becoming available. If individuals have a BMI over 35 and an Edmonton Obesity Score of greater than 2, then I would strongly advise that there's a very good discussion with them about whether they should be going for a bariatric surgery, as that's the only thing that's going to be shown to change their mortality over the coming 200 months. Similarly, if we're thinking about people without type 2 diabetes, again, if they've got PCOS, then we think about metformin, Orlistat, and then consider GLP-1 if the weight loss isn't enough. If they've had previous cardiovascular events, then semaglutide would be the choice. If they've got heart failure, then SGLT2, and then considering semaglutide. If none of the criteria, then semaglutide, if able to get that. But then as soon as Tirzepatide, which we hope will be available to primary care in kind of October time, then we should replace that, because these individuals haven't got any cardiovascular risk or chronic renal failure, so it doesn't matter if they get an agent that isn't shown to be protected before those. In terms of what we thought about prioritizing Wegovy, we have worked with the Society of Endocrinology and a number of other boards to come up with what we would see as prioritization, and have 4 phases. So this is the first phase, the people who we're trying to get it to at the moment. So these are the priority phase 1. So people with precancerous conditions, people requiring urgent weight loss for organ transplants, people who have very severe disease such as intracranial hypertension or severe sleep apnea, and people who have genetic causes of obesity that aren't eligible to the semaglutide because they seem to respond very well to GLP-1. There's then phase 2, so people living with obesity and 3 or more weight-related things. So those are the individuals, who are at Edmonton obesity score 3. And then at phase 3, individuals with 2 or more, and then the rest eligible. So I'll finish there and answer any questions. Hopefully that has been helpful.
Thank you very much, Rob. Yeah, we do have questions. So we'll kick off in the Q&A box. So the first question is, can metformin cause hypoglycemia?
I would say not. In the trials, there have been reported people having hypoglycemia, but in situations where you really can challenge people the most, they don't get hypoglycemia. So I do some work in Africa where individuals have to walk for 3 hours to their diabetes appointments and things, and don't have any food, and at that point they still don't go hypoglycemia. So I don't think I would class it as an agent that doesn't cause hypoglycemia.
Okay, perfect. And then the follow-on question from that was, does EMPA cause more weight loss than DAPA?
It does appear to in that network analysis. It's always really difficult because the drug companies avoid doing head-to-heads so that you can say that one's better than another. But it does appear to in that network analysis. Unfortunately, in that network analysis, there isn't the 25 milligrams of the EMPA, so it would be interesting to see if that was even higher. But it does appear to cause greater weight loss.
Okay, brilliant. The next question was, if someone follows a low-calorie diet and are on empagliflozin, should this be stopped?
So SGLT2s, the evidence is if you're on a low carbohydrate, so you're following, as it were, a ketone diet, then your risk is greater of ketoacidosis. That would be in people with type 2 diabetes. I can't hand on the heart say for people who haven't got type 2 diabetes that you would see an increased risk. My advice would be just on a pragmatic point of view not to do it. But if you said hand on heart, is there evidence that they're going to go ketotic on the DAPA? There isn't any evidence to support that.
Okay, perfect. Do you use GLP-1s in people with type 1 diabetes with obesity?
So I do personally, yes. There are trials in people only with liraglutide, has been tried, and they're also and they have shown a significant weight loss. The difficulty is that they have an increased risk of hyperglycemia and an increased risk of ketoacidosis. One way found in the trials that predicts that is if people still have some of their own C-peptide around, which you can measure, then that risk is a bit less. If they've got no C-peptide, then the risk is a bit higher. So I tend to measure the C-peptide. If I can see a bit of C-peptide, then I'm willing to take a chance. If they're not got any C-peptide, then I'm very much more risk averse and don't tend to go for it.
Okay, brilliant, thank you. Please could you also cover your thoughts, Ari, the evidence for children with obesity and potentially pre-diabetes rather than those with type 2? Thank you.
So, metformin is licensed for children from the age of 12. So that can be used in individuals if there is a kind of worry about kind of pre-diabetes and things from there. And Orlistat, can safely be used. For weight loss, there are GLP-1s that are available now for individuals. So again, there are available to be used. The progression, is going to be similar in people who, if they've got pre-diabetes in children, then I can't see any reason why giving these agents won't help with weight loss. But again, there aren't very good trials that show that, with trials have concentrated in adults.
Okay, brilliant, thank you. Can Tirzepatide, sorry about my pronunciation, Tirzepatide be prescribed in primary care?
At the moment, yes, only for people who've got type 2 diabetes. They have to have a BMI greater than 35, and a bit like the other GLP-1s, it's recommended as a third line agent, or individuals who haven't been able to respond, haven't been able to tolerate the other agents, from that point of view.
And following on from that, is it only available? So it's only available for people with diabetes, but I have a patient who's gone into remission that would also find it useful. Are you able to prescribe for them?
So the NHS isn't able to prescribe. Obviously, privately you can get Tirzepatide, so Mounjaro. So Boots do it, and other companies do it. There is a NICE document that was out for comments that closed about 10 days ago, and the plan is to hear the NICE outcome in October. The document suggested that rather than like semaglutide, it's going to be prescribed in only secondary care clinics, is that the prescriptions would be available to be prescribed by GPs in GP land. So I think it's going to go along kind of similar to that they can prescribe it for diabetes and for people who are overweight.
Okay, brilliant, thank you. And does the effect of it continue even after lifestyle mod? Sorry, I'm struggling to read this one. Does the Tirzepatide effect continue even after lifestyle modifications are stopped during treatment?
So in the follow-up trials, individuals were just followed up, and those individuals on it still had good weight loss. It's difficult to know whether they continued the lifestyle habits that they would in the trial. I suspect not. It's very difficult to do it. So I suspect it does continue to have a weight loss effect. When you talk to Boots or other private people who give this, they've been very surprised as to how little support they have to give individuals to get very good weight loss. And the wraparound care hasn't been as big as they were expecting it to be. So that's, I think, indicating that stopping the appetite is enough for these individuals to be able to make the changes they need to make.
Is there any evidence at when starting a liver reducing diet, carbs around 80 to 100 grams per day pre-bariatric surgery, and at what point can I stop SGLT2 inhibitors? Currently, I advise at the start of the diet.
So there's good evidence that that going on to a low carb diet prior to bariatric surgery shrinks the liver, and we're doing it to shrink the liver because particularly if people are having a bypass, so you can't get to the part that you need to bypass if the liver is too big and too tough, so too full of glycogen. In terms of, is there a study that has looked at when to stop the SGLT2? No, there isn't a study, but we just give the same advice that we give if people go on to low carbohydrate diets, that stop it because of that risk of ketoacidosis, and see what happens to the glucose. In most of those individuals, if they truly got type 2 diabetes, then reducing the calories, their glucose just gets better instantly from them.
Okay, brilliant. Any thoughts on oral semaglutides for young people or teenagers without type 2 diabetes?
So it's obviously it's not licensed for that use. The weight loss with oral semaglutide isn't as great as the injectables for it and things. Certainly not something I've used in that situation. I would much, because of the fact that Saxenda is available for that age group, I would be using Saxenda. Although again, that's starting to become difficult to control. But obviously, I'm a secondary care physician, so I get access to Saxenda. But I'm guessing I don't see any. This is picking off license. I don't see any. If the need to lose weight is enough, and that's the only thing that can be got, then I think it's worth a try.
Thank you. It looks like GLP-1 is more useful in CVD and SGLT2 for heart failure.
Sorry, I missed the first bit.
It's more of a statement than a question, I think. But so would it be correct that it looks like GLP-1s are more useful in CVD and SGLT2 for heart failure?
Yeah, I don't know if you can definitely say the scope of use of the GLP-1s is greater for cardiovascular disease than the SGLT2s, in that they've got clear data for individuals who have just had a cardiovascular event who don't have diabetes, whereas the SGLT2s don't currently have that. But the SGLT2s are helpful for people with diabetes who have cardiovascular events and are helpful for heart failure.
Please, could you share the criteria for Tirzepatide, please?
So Tirzepatide is BMI over 35. At the moment, BMI over 35, have type 2 diabetes, and have tried other agents to help with their glucose control. So at the moment, it's kind of badged as a diabetes drug rather than a weight loss drug for people with diabetes. So it's there to improve control, but also helps with weight.
Okay, thank you. Can a patient take Orlistat, Metformin, and GLP-1s all at once?
They can do. So there's no reason why they can't. They might find it difficult to tolerate. I have had people who have done that, but it generally is very difficult to tolerate. So most people can't manage it.
Yeah, thank you. Do we stop diabetic medicines straight away post-bariatric surgery if BMs remain within normal range?
So so when you have bariatric surgery, for the first 6 weeks, you have to go through a period of going from liquids to kind of mushy food to then semi-form food and then to food. And during that period, we don't give them any, if they're on oral medication, we stop their diabetes medication. Obviously, they're on insulin, we make changes to their insulin. And then once they get back on to the thing, we tend to return them to Metformin 500 twice daily. We don't go above the dose of twice daily, just because of all those effects I was talking about with Metformin, that in people who have had type 2 diabetes, it prevents cancer, seems to prevent Alzheimer's disease, and it will prevent diabetes returning. So about 50% of people who get diabetes remission with their surgery over the next 6 years will see their diabetes return. So obviously, if you give them Metformin, then you lessen that chance.
Okay, thank you. Can you use SGLT2 in non-diabetics for weight loss alone?
It's not licensed for that, no.
For most people, are these drugs intended to be used for life, or is the plan for them to use them as a form of induction to weight loss while establishing healthier behaviours?
Yeah, so the way the NHS are hoping that we're using them is for induction of weight loss, and for changing styles that at the end of it they would then be able to maintain. So currently, unless you've got diabetes, if you're using the GLP-1s for purely weight loss, it's only licensed in the NHS for 2 years. So they're only able to get it for 2 years. Interestingly, the Tirzepatide NICE thing didn't seem to indicate a stop point, so maybe opinions are changing. It's unfortunately makes no logical sense, because we know that with the drugs, as soon as you stop them, that they do regain the weight, because all you're doing is reintroducing the appetite, and most people will go back to the point that they were before when you stop it. And there's no other medication that we give for any other disease that we expect it continue to work after you stop taking it. But it is financially, we have to think about the finance. So and there is some evidence that if people lose weight and have a period of being a lower weight, that they get protective changes that last even longer than the weight's off for. So you can make an argument that you are saving the NHS money, even if these people only keep the weight off for 2 to 2.5 years.
Okay, thank you. Do you have any experience of patients responding to Tirzepatide despite previous poor response to GLP-1s in terms of kilograms?
Yes. So that's, and I probably didn't highlight that kind of in the thing. So within GLP-1s, it does appear it's worth trying other GLP-1s, because so if they didn't respond to one GLP-1, it's always worth trying another GLP-1, because people can respond to that one. So it's not a ubiquitous response across across them. And again, the tolerance are different for different people. So some people can find that they can't manage liraglutide, but then if you tried semaglutide, actually they can tolerate it and they get weight loss. And it does seem to be the same for Tirzepatide. So there are people who haven't lost weight on the GLP-1s we tried, but when we tried Tirzepatide, they have lost weight.
Yep. Thank you. Is 10 milligrams EMPA as effective as 25 milligrams, or is it always better to optimize EMPA to 25 milligrams? As some have CKD, so we try to keep them at 10 milligrams, and some have SE on 25 milligrams, so we go back and keep them on 10, which they tolerated.
Yeah, I mean, in the trials for protection, there didn't seem to be very much difference between 10 and 25. There is a small difference in the glucose lowering that you're getting from the difference between it's 10 and 25. Likewise, surprisingly, there wasn't really much difference in the side effects between the 10 and the 25. So you know, I generally go up to the 25 if people can tolerate it, but don't worry if they can only stay on the 10.
Okay, perfect. Right, so we have got a few more questions, which we'll try and power through as quickly as we can in the last few minutes. That's okay, Rob. So do you have any experience in Tirzepatide in people with type 1 diabetes for weight loss, preconception, to meet the NHS criteria for IVF?
Yep. Yes, so I have used it in that situation. From that point of view, I tend to be quite pragmatic in that point of view. So people who are going to who've got type 1 diabetes who are going for pregnancy can go on to a closed loop. So that's a bit where the sensor talks to the pump, and in that the chances of ketoacidosis are tiny. So I'm ruling out the chances of ketoacidosis. So I get them on that first, and then get them on to the Tirzepatide or the GLP-1. They take the contraceptive until they've got the weight loss that they require for it.
Okay, perfect. Please, can patients have GLP-1s after gastric bypass?
Can they have it? Did you say? Yes. And there is a very nice meta-analysis that shows that non-responders to who haven't done as well with bariatric surgery still get a benefit if they go on to GLP-1s after surgery, and also that you get additional weight loss in individuals who you haven't got to the weight that you were hoping to get them with surgery.
Okay. Do you have a view on co-prescribing Orlistat and Tirzepatide in non-diabetics?
Only done it a couple of times. I think the reason for that is that if they respond to Tirzepatide, they're getting such good weight loss that thinking about something that might upset the apple cart and cause indigestion and other problems probably isn't worth it. I've only done it in cases where surgery's been held off, and sillily, but for a few kilograms, and that adding in Orlistat has enabled us to get them to that weight.
Okay. Is there going to be extra support for primary care colleagues, for instance, more dietetic input when the NICE guidelines for weight loss become in place for primary care, considering the numbers of people that will be eligible?
I'm not sure, to be honest. It would be sensible if it was, but NICE doesn't always come with a tag. So a tag is money attached to it. And to date, the drugs haven't come with money attached to it. So I suspect it won't come with money attached to it. So it would be more of reallocating whatever is available. Interesting, as I said, the companies that have rolled it out have been very surprised that the uptake of people wanting to talk to dietitians, wanting to get advice, has been miles less than they anticipated it to be. So the wraparound care won't need to be as much as we anticipate.
Thank you. We've just got a final few that we'll whiz through. For anyone that needs to go, I'm really sorry that we're running over, but I just really want to get as many questions answered as possible. So although Tirzepatide has weight loss comparable to bariatric surgery, it is only licensed for 2 years. Therefore, for lasting weight loss, would you say that bariatric surgery is the definitive option?
Yes. So yeah, bariatric surgery, and it's the only one currently that all-cause mortality is improved in these individuals. So yes, if they are up for it and they can manage it, and it's also more cost-effective for the NHS.
I think we might have answered this one already, but just in case we haven't, thoughts on Tirzepatide in type 1 obese people?
So as I say, there's no trials. It's only liraglutide that there are trials in people with type 1 diabetes. I have occasionally used it, but under very fixed conditions, that there's a really clear reason what we're going for, which tends to be they can't have surgery for a reason, or they've got cancer and they're saying they can't have surgery, or fertility.
So final two, do you think oral semaglutide, will be licensed for children with type 2 diabetes anytime soon?
Yeah, I'm obviously not a pediatrician, but I can't see why it wouldn't be, because the other ones have been licensed. I'm not sure if it even has a license. I'd have to look that up. I'm sorry, I'm not a pediatrician. So.
Perfect. And this one follows on to a question that we did have earlier about GLP-1s post-bariatric surgery. So thoughts on using them in type 2s who have regained weight post-bariatric surgery?
So again, I don't have a problem with that. The data shows that it's helpful, and I don't see any reason why, if everybody else can get the people who've had bariatric surgery shouldn't be able to get it.
Brilliant. Thank you very much. That's it. I think we managed to whiz through as many as we can. So well done, Rob. That's been really, really helpful.